Bismillahirrahmanirrahim. Good morning, everybody. As the name indicates, osteosarcoma. So it's derived from the. So this is the sarcoma of the bone. It is the most second common malignancy in pediatrics. It's characterized by the production of osteoid, and it's the most common non-hematological primary bony malignancy. And it's mesenchymal in origin. There is a difference between sarcoma and cancer. Cancers are usually arise from the epithelial cells, and sarcomas arise from the mesenchymal cells. And osteoid is produced by the spindle shapes. The incidence is 1 to 3 per million per year. Primary high-grade osteosarcoma most commonly in the second decade of life. And most probably in 12 to 14 years of age, usually before 20 years of age. And parosteal osteosarcoma has a peak incidence in the third and fourth decades of life. So jiski aap baat kar rahe the, you are talking about that hockey player, he had that parosteal osteosarcoma. It's a different kind of osteosarcoma. And the incidence is slightly higher in males. Distribution is slightly higher in male in first and second decade of life. Locations, the most common location in distal femur and proximal tibia is it arises from the mesenchymal cells. So you can imagine about the metaphysis, which is the rapidly growing side of the body and high risk of malignant transformation. 60% proximal tibia and distal femur arise from the mesenchymal cells. In the metaphysis is the origin, and 15% proximal femur, ilium, proximal humerus, and mandibles. Molecular derangements in osteosarcoma: mutations in RB gene, retinoblastoma gene, mutation in P53 gene, and MGM2 implications, our expression of HR2 and ERB2, but still no single molecular derangement defines osteosarcoma. The pathophysiology is still unclear about it. Associated conditions, it could be associated with retinoblastoma, Lefaunémi syndromes, Rothman-Thompson syndrome, Bloom syndrome, and Warner syndrome, and fibrous dysplasia. Classification is based on primary and secondary. The primary that arise from the primary origin, primary from the bones, and the secondary usually from the secondary sites like from the Paget disease or radiation induced areas. And primary is further classified on the grade of the tumor, on the basis of histological grades. It could be primary is further classified into high grade, intermediate grade, and low grade. First is conventional, which is the most common. It includes 90% of the osteosarcoma, which is most common high grade intramedullary tumor, and it breaks the cortex, leading to that sunburst appearance. You have known about it, and soft tissue mass. Low grade intramedullary, which is rare, and indolent course, benign features on radiograph. Again, the parosteal osteosarcoma, which appears in the second, third, and fourth decade of life, it's very rare. Low grade arises on the surface. It arises from the surface, not from the medullary tumor. So it's different from the conventional tumor. It arises from the surface of the bone, and it arises from the medullary tumor, from the medulla. Another which arises from the surface of the bone is periosteal osteosarcoma, which is intermediate grade and high grade surface, which arises from the surface but is high grade. It's a least common, aggressive in nature. Telangiectatic, it's a pleuritic lesion. It can have a balloon appearance similar to that of aneurysmal bone cyst. Small cell, it's a very rare variant. It's a high grade tumor, consists of blue cells and resembles Ewing sarcoma. So the one was the primary and other is the secondary. In primary you have high grade tumors, intermediate tumors and low grade tumors. Secondly, you arise from the disease process or disease sites. It is very rare in youngs, mostly associated with Paget disease and previous radiation treatment. Usually arise after third and fourth decade of life. Can be associated with fibrous dysplasia, bone infarcts, chronic osteomyelitis. Clinical features, obviously rapidly progressive pain, night pain which occurs in 25% of the patients. Average delay of the patient, their presence to OPD in emergency department about almost 15 weeks, 3 to 4 months. Swelling and symptoms of METs. The success of management depends on the separate of the tumor. Initially it is localized tumor or it is METs, and the behavior of the tumor as we discussed already, high grade tumor, intermediate tumor and low grade tumors. So the investigations after clinical examination, thorough history, you are going to do investigation, plain x-rays, most valuable investigation, MRI, CT scan and angiograms. So you can see in an x-ray, it is an aggressive lesion in the metaphysis of the bone. You can see the blastic and sclerotic lesions, lesions with ill-defined borders, extent of the tumor within the bone, for the skip lesions and soft tissue extension. CT chest, angiogram for the vascular involvement, bone scan for the extent of the region in the other bones, chest X-ray for METs workup. All these X-rays, MRI, labs and angiogram, plus minus and bone scan, chest X-ray, CT scan chest, these should be done before biopsy. So this is the MRI of the lesion showing the extracompartmental extension into the soft tissue. CT scan, angiogram. This is the bone scan showing multiple METs. Differential diagnosis, after once you have done clinical examination, investigations, and then you come to the differential diagnosis. Before doing biopsy, it could be giant cell tumor, aneurysmal bone cyst, as we have discussed already, is a rare, Ewing sarcoma, osteoblastoma, METs and lymphoma. So once you have done all the investigations and you made your mind clear about, then you're going to do biopsy. So there are types of biopsies: fine needle aspiration, core needle biopsies and open incisional procedures. So we do biopsy as a careful planning as definitive procedure. So before doing biopsy, clinical labs, radiograph examinations are complete. So once you have planned for biopsy, the biopsy tracts need to be excised and blocked with the tumor. Application of tourniquet, transverse incision for biopsy should be avoided. Deep incisions through single muscle compartment. Hole must be made in the bone. It should be round or oval. Periphery of the lesion contains the most viable tissue. So this is a round, oval shaped. Poor biopsies can lead to pathological fractures. If you could not make a proper hole or oval in the bone, it can lead to pathological fractures, which is a nightmare for the patient and for the surgeons as well. So this is anything staging system for the tumor, osteosarcoma, depending upon the grade, site. Stage 1A, it's a low grade intracompartmental, low grade intracompartmental. 1B, low extracompartmental. Extracompartmental, that means it has break the cortex. Okay. To a high grade intracompartmental. Very easy classification. 2B high grade extracompartmental. 1A, 1B, 2A, 2B. Intracompartmental, extracompartmental. High grade, low grade. 3 with mats. This is American Joint Core classification staging systems, depending upon size of the tumor actually. Size of the tumor. As a classification is almost same, low grade, high grade. Prognostic factors, extent of the disease, grade of the lesion, size of the tumor, skeletal location, proximal to worse than distal. Other poor factors are pigid and radiation-induced osteosarcoma. Age and gender have no prognostic significance. So the main thing is the treatment of this osteosarcoma. Once you have done investigation, you have done a proper biopsy, and you made your mind clear it's osteosarcoma. Current treatment, long-term survival has improved from 20 to 5%. 5-year survival rate is 20 to 70%. The most technical aspect in the osteosarcoma is white margin resection. White margin resection with the advanced technologies of new adjuvant chemotherapies, radiation, we have achieved white margin. It's a limb salvage surgery. Could be radical resections, wide resections, marginal resections, and debulking for the huge tumors. So the wide resections, dissection carried out clear of the tumor through the normal tissue, chemotherapy for stage 2A, and the radical resection, in-block resection for 2A and 2B tumors. Local procedures, as we discussed already. So limb salvage surgery, like wide resections. So we have 3 types of treatment in osteosarcoma. Number 1, limb salvage surgery. Number 2, जो है वो है amputations. And number 3, we do have endoprosthesis or prosthetics, allografts. Limb salvage considered only if local control obtained is good as with amputation. Earlier we used to do amputations. There should be no skip lesions. Functional limb can be preserved. It is performed in 90% of the cases of osteosarcoma. Limb salvage we do in 90% of the cases of osteosarcoma. It's only be done if good control is obtained, good function is obtained. No, there should be no skip lesions. Function should be preserved. So, wide excision of the tumor, the aim is to preserve neurovascular structures, the distal neurovascular structures, and the function of the limb should be achieved if you are planning for wide resection. If you are doing wide resection, the wide resection should be reconstructed. If you are doing wide resection, if we are removing the part of the bone from the body, it should be reconstructed by vascularized or non-vascularized bone graft, custom-made prosthesis, endoprosthesis, allograft, osteoarticular allograft, prosthetic composites, and expandable implants in children. So limb salvage has a greater perioperative and long-term morbidity compared with amputation. A much more extensive surgical procedure obviously as compared to the amputation. Greater risk for infection in limb salvage surgeries, wound dehiscence, flap necrosis, blood loss, and deep vein thrombosis. Long-term complications in limb salvage surgeries, periprosthetic fractures, prosthetic loosening and dislocation, non-unions, allograft fractures, LLD, and late infections. osteoarticular allograft. So once you have removed the part of the bone, you're going to reconstruct that part with osteoarticular allograft. If you are removing part of the intra-articular portion of the distal femur or proximal tibia, the complication rate is high, non-union, fatigue fractures. If you are doing osteoarticular allograft, it can lead to articular collapse, dislocation, degeneration of the joint disease, failure of the ligaments and tendon attachment. So another, this is allograft prosthesis composite. This is the main indication is inadequate length of remaining host bone to secure to stem with the endoprosthesis. Avoid complication of degenerative joint disease and articular collapse. जो earlier जो था जिसके अंदर articular collapse के chances ज़्यादा थे, the one we are using with osteoarticular allograft prosthesis had low chances of articular collapse. Complications still include fatigue fractures, infections, non-union. So this is allograft prosthesis composite. We are removing this part of the humerus. This is almost a radical dissection, radical excision, and this is allograft, and this is prosthesis. It's a prosthesis, it's an allograft. So this is allograft prosthesis composite. Endoprosthesis is compared to amputation, immediate stability, quicker rehab. These are modular, allowing for limb length recumbencies, and protected ambulation is begun on first post-operative day. Keep the knee in full extension for 6 weeks. That is for something. So this is another tumor in the metaphysis of proximal tibia, breaking the cortex. So what we're going to do for this, we have planned to do wide resection and do some endoprosthesis. So you have removed the bone of proximal tibia and you're going to put endoprosthesis. You are replacing the articles with ceramic knee replacements and prosthesis. This is a part of the tumor. Pediatric patients. So in pediatric patients, what we want to achieve is expandable devices, so we could achieve the length of the legs, so we could achieve growth of the bones. So we use expandable prosthesis, being able to gain 0.5 to 1.5 centimeter during each scheduled expansion sessions. So these are the expandable devices, externally controlled or internally controlled. We do have two options, externally controlled or internally controlled. These are externally controlled devices. So you can see almost 1 centimeter and here can see 2.5 centimeter expansion. We do only on 3 or 6 month schedule basis. So come to the amputation. So we talked about wide resections and reconstruction. One option is wide resection and reconstruction with the allograft prosthesis, with the endoprosthesis. The other option is amputation. Amputation could be radical, could be wide amputation, marginal, intralesional. For high grade and extra compartmental tumors, amputation is for high grade and extra compartmental tumors that have involved soft tissue, that has involved neurovascular bundles. It may be curative, technically demanding in malignant tumors, often requiring standard flaps for closure. May need bone graft augmentation obtained as functional residual limb. Again, the complications are infection, wound dehiscence, chronically painful limb, phantom limb, outgrowth, a positional bone outgrowth requiring revision of the surgery. In high-grade tumors, we do neoadjuvant chemotherapy to treat micromets, to reduce the size of the primary lesion before going to do any definitive surgery. Drugs we use methotrexate and MAP techniques given for 8 to 12 weeks. Neoadjuvant chemotherapy is given for 8 to 12 weeks before surgery. Then surgical treatment, we have two options. Again, limb salvage. What do we do in limb salvage? Void resection and reconstruction. The aim is to achieve the function and length discrepancies. Another option is amputation. So once you have done surgery, obviously you're going to do with the adjuvant chemotherapy. The maintenance chemotherapy is given for 6 to 12 months. Pulmonary mets resected if possible after neoadjuvant chemotherapy. सर किया क्या आप कभी आपने कर दिए? अच्छा आइसोलेटेड मेट्स के अंदर, अच्छा वाइड स्प्रेड में आइसोलेटेड मेट्स हो, कोई साइज तो होगा ना सर उसमें? ठीक। सो हाई ग्रेड के अंदर आप क्या कर रहे हैं जी? neoadjuvant कीमोथेरेपी देंगे, neoadjuvant कीमोथेरेपी देंगे, उसके बाद आप सर्जरी करेंगे जिसमें लिम्ब सैल्वेज होगी और या एम्पुटेशन होगा, या उसके बाद एडजुवेंट कीमोथेरेपी आप देंगे। जब लो ग्रेड होगा तो उसमें क्या करेंगे? वाइड रिसेक्शन, एम्पुटेशन विदाउट कीमोथेरेपी, लो ग्रेड ट्यूमर्स के अंदर। पर इस पेशेंट को हमने फॉलो पे रखना है सर, हम उसको हर 3 मंथ्स फॉलो पे रखेंगे। सो द करंट स्टैंडर्ड ऑफ ट्रीटमेंट, प्री ट्रीटमेंट रेडियोलॉजिकल स्टेजिंग, हाउ वुड यू डू? एक्सरेज, MRI, CT for meds, chest X-rays, LDH. Why we do LDH? मेटाबॉलिक बोन डिजीज़ है, इसमें LDH रेज होगा। अल्कलाइन फॉस्फेटेज करते हैं, इसके प्रोग्नोसिस फैक्टर्स में आता है, जो मैं भूल गया मेंशन करना। अल्कलाइन फॉस्फेटेज, LDH, लैक्टेट डिहाइड्रो, LDH जहाँ पे रेज हो और अल्कलाइन फॉस्फेटेज जहाँ पे रेज हो, इट्स अ हाई ग्रेड ट्यूमर। बिफोर डूइंग सर्जरी वी डू स्टेजिंग, then biopsy, then next chemotherapy। हाँ ग्रेड पे है, ग्रेड पे, लो ग्रेड में वैसे जब मरीज, मैंने लो ग्रेड आज तक देखा ही नहीं सर। मरीज जब भी हमारे पास प्रेजेंट करता है वो हाई ग्रेड ट्यूमर ही होता है, उसमें तकरीबन नहीं तो स्किप मेट्स तो ज़रूर होते हैं, एक्स्ट्रा कंपार्टमेंटल ज़रूर होता है। मरीज हमारे साथ ज़्यादातर आता है पैथोलॉजिकल फ्रैक्चर्स के साथ, जिसमें 20% ऑफ द केसेस प्रेजेंट विद पैथोलॉजिकल फ्रैक्चर इन ऑस्टियोसार्कोमा, 20% ऑफ द केसेस। स्टेजिंग, बायोप्सी टू कंफर्म डायग्नोसिस, देन neoadjuvant chemotherapy, देन दोबारा से करनी है आपने स्टेजिंग। स्टेजिंग करेंगे तो फिर आप सर्जरी की तरफ जाएंगे। हाँ, डाउन स्टेजिंग के लिए आप दोबारा सर्जरी करेंगे, दोबारा आपने स्टेजिंग करनी है। देन सर्जिकल रिसेक्शन विथ वाइट मार्जिन और एम्पुटेशन, reconstruction or amputation. Being a surgeon, I will prefer to do reconstruction, which is one of the difficult techniques. Amputation is could be easy depending upon the grade of the tumor. Post-op chemo, based on pre-op response के लिए आप क्या करते हैं? Pre-op जब आप neoadjuvant chemotherapy जब करवाते हैं तो what you do, आप जब उसकी बायोप्सी को एसेस करते हैं तो उसमें देखते हैं कि इसमें वायबल टिश्यू कितना है। अगर लेस देन 10% वायबल टिश्यू है तो गुड रिस्पॉन्स, तो सेम कीमो आप लेके जाते हैं, सेम कीमोथेरेपी पोस्ट ऑप भी। अगर वायबल टिश्यूज में ज़्यादा है, अगर खुदा न ख्वास्ता उसमें पॉजिटिव मार्जिन हैं, देन यू हैव टू चेंज योर प्लेन्स। अगर इट्स नेगेटिव मार्जिन है और लेस देन 10% वायबल टिश्यू बायोप्सी के अंदर है तो यू गो विद द सेम neoadjuvant जो आप यूज़ करें वो एडजुवेंट कीमोथेरेपी उसको देंगे। व्हाट एल्स? Sir, do you remember this photo?